Hello, everyone. We're so glad you're here today. Welcome to today's webinar, Early Recognition and Treatment of Neuroimmune Psychiatric Conditions, a Paradigm Shift in Neuropsychiatry, presented by Dr. Juliette Madan. My name is Susan Boaz. I'm the Executive Director of the PANDAS Physician Network. PPN is a nonprofit organization with a vision that PANDAS will become easily diagnosed and treated with accessible therapies that dramatically reduce suffering and lead to a cure. Today's webinar is hosted by PPN along with the support of the PACE Foundation. Today will include a live presentation followed by Q&A. You can send questions via the chat function below. We do ask that you keep questions relevant to the content discussed in the webinar, and we are unable to give medical advice. Now I'd like to welcome our presenter, Dr. Juliette Madan. Dr. Madan is a physician scientist, pediatrician, and psychiatrist at the Children's Hospital at Dartmouth-Hitchcock. As the director of the Neuroimmune Psychiatric Disorders programs, Dr. Madan takes a holistic view of how physical illness intersects with neuropsychiatric symptoms. Finding the underlying cause of diseases in children has been Dr. Madan's passion for more than a decade. She's a professor of pediatrics, psychiatry, and epidemiology, and a faculty member of the Quantitative Biomedical Sciences graduate program at the Geisel School of Medicine at Dartmouth. In addition, her role as clinical director of research for the Geisel's Children's Environmental Health and Disease Prevention Research Center, her research is focused on the developing microbiome in relationship to health and disease, and more broadly, in epidemiological, clinical, and translational investigations in neuroimmune psychiatry. Dr. Madan, welcome, and thank you for joining us today.
Thank you so much. And I really want to thank the PANS Physician Network and the PACE Foundation for the opportunity to speak with your audience today.
We're so glad you're here.
So thank you for the kind introduction. I have no financial conflicts of interest. I do have research funding from the National Institute of Health and some foundations, including the PACE Foundation and the Alex Manful Fund Foundation. So I'm going to start just speaking a little bit about psychiatry. So I came to psychiatry from medicine. I trained first in pediatrics and then neonatal intensive care. I was a neonatologist and a physician scientist, and trained later in my career in psychiatry to align with a lot of my interests with respect to my research. So what is psychiatric illness? I wanted to share some highlights from the lay press to have us think a little bit about psychiatric illness, how we define it, and how we diagnose it in medicine more broadly. During the COVID pandemic, we were really asked to ask the question about the immune system and how it might relate to people with very severe mental illness like schizophrenia. The people who are dying, unfortunately, from COVID infection were people who were over the age of 85 or young, healthy people who had schizophrenia. And that was a signal that perhaps there's some immune dysregulation in the setting of having a diagnosis of severe mental illness like schizophrenia. Can an infection suddenly cause OCD? Well, yes, it can. And we'll talk about that in great detail today. Some other really fascinating articles about a woman in a state psychiatric hospital for over 20 years, considered treatment refractory for her primary psychotic illness. And in fact, she was then identified one weekend by a rounding psychiatrist as having an autoimmune condition. She had undiagnosed lupus. When that was treated appropriately, her psychotic illness melted away. There are case reports of people with treatment-resistant psychotic illness that resolves after bone marrow transplantation. And this article, I would really encourage you to read, was recently in the New Yorker. Mary had schizophrenia, and then suddenly she didn't. And again, this was another case of a woman, physician herself, actually, who had psychotic illness for 20 years from the ages of 40 to 60, and then had treatment for B-cell lymphoma with rituximab. And with that treatment, her psychotic illness melted away. So I think these are good examples of thinking about where does the body relate to the brain? And how do we think about psychotic illness? How do we think about OCD and other conditions we call psychiatric as physicians? This cartoon really helps me think about the way that I work with my partners in neurology. I practice both pediatrics and psychiatry. The separation between neurology and psychiatry, between medicine and psychiatry, I think is a false separation. And I think that today I hope to express the importance of integrating our evaluation and treatment in this space. So this is my outline for today. I'm going to be talking specifically about clinical features and psychiatric presentations of PANS and PANDAS. I'm going to talk a little bit about what we call primary psychiatry and how to identify neuroinflammatory driven symptoms in children and adolescents. I'm going to talk about evidence-informed and evidence-based strategies for psychiatric evaluation, treatment, and team-based collaboration, which is my favorite part of my job. And then psychiatry specifically, I really want to sort of let everyone know I feel like it's going to be incumbent upon people who practice in mental health, in psychiatry, psychology. We have a very unique role in connecting medical perspectives to what we call mental illness. And immune-mediated neuropsychiatric disorders are a very obvious place to learn and to grow in that space. So I'm going to start with a case. This is a case, a 7-year-old patient who presented to my clinic with acute onset OCD. This is a very, very great example of a lot of what we see in our clinic that I wanted to talk about today. So this little boy had a very typical developmental history, really no significant struggles with any symptoms that might be related to psychology or psychiatry. He developed strep pharyngitis when he was in the 2nd grade and was treated with antibiotics by his PCP. 2 weeks after finishing his antibiotic course, he developed an abrupt overnight onset of severe OCD. It was contamination fears, fears about germs, becoming sick, began hand washing excessively throughout the day, and also had cleaning rituals. He, at the same time, had sleep disruption, was unable to fall asleep for hours and hours every night, and throughout the day and at nighttime would have new onset rage episodes that were triggered by nothing that the family could identify. He also developed both motor and vocal tics at the same time. And a very sensitive and specific sign I'd like for you to remember is that he developed urinary symptoms. Urinary frequency so frequent that when they would leave the house to go to a store, he would have to go to the bathroom up to 10 times an hour, really urgently and frequently, feeling like he wasn't emptying his bladder. He developed secondary enuresis. He was wetting his bed again after being toilet trained for years, and had very significant behavioral regression, was talking like a baby. He was interested in toys that were much more commonly used when he was much younger, and very severe inattention, notable cognitive changes both at home and at school. His team was aware of the possibility of the diagnosis of PANS and PANDAS. He had a referral quickly to our multidisciplinary team and had a multidisciplinary evaluation. That includes physical exam, neurologic exam, history taking, as we would all do, and a specific panel of labs I'll be describing today. His initial labs were notable for a very low white blood cell count. He had evidence of very severe sinusitis on examination. And his antibody titers against strep were almost sort of above the limit that is measurable. They were so high. He was then treated again with antibiotics, as well as scheduled anti-inflammatories. And within about 4 weeks, he was exhibiting a measurable 80% reduction in his OCD symptoms and all of the associated very disruptive symptoms that I described. As soon as we met this patient, we referred him for exposure response prevention therapy, as well as parent management training. There's a multitude of different evidence-based parent training around OCD and anxiety in younger children. And he was eventually started on a very low dose of an SSRI, which is an evidence-based intervention for OCD as well. This second case, I wanted to share more of an inpatient lens on this group of conditions. This is a 10-year-old who developed acute onset OCD, very similar to the other patient, but she had very disruptive, very severe psychotic features. She had no previous medical or psychiatric history, and she had the only documented infection prior to the onset of her symptoms was COVID. 3 weeks after her COVID infection, she developed abrupt onset OCD, sleep disruption, inattention, and cognitive changes in urinary frequency. And so I think you might be sensing a pattern. Her OCD symptoms were severe. She developed visual hallucinations, auditory hallucinations, and she did not recognize her parents. In fact, she recognized that her parents were not who they said they were, which is a condition in psychiatry we call capgras. Her symptoms were so severe, she was actually hospitalized at her local children's hospital. And the hospitalist consulted neurology. I just want to point that out. So there was a differential diagnosis in mind for her team. That neurologist ordered an electroencephalogram and EEG. They did a lumbar puncture to study her CSF, and they did an MRI. And all of those studies, as they were initially available, were read as reassuring. So neurology signed off and recommended that the hospitalist team have a psychiatrist come and see her. The psychiatry team treated her with an antipsychotic medication, Zyprexa, and fluoxetine, an SSRI. And then the decision was, where should we go next? Should we send her home, or should she be hospitalized on an inpatient child psychiatry unit? The decision was made to send her home, and that was based primarily on the parents' preference. They didn't feel that she would tolerate being hospitalized separated from them because some of her OCD symptoms and her psychiatric symptoms were very severe separation anxiety. She was struggling with eating and using the toilet without her mom. When she got home, her symptoms worsened. She developed very severe avoidant restrictive food intake disorder, or ARFID, and lost 10% of her body weight. She could not do her homeschool curriculum. She couldn't follow directions or do her chores. She developed severe behavioral dysregulation, irritability, ongoing OCD, and wasn't sleeping. She was referred to our program. And we really involved all of our specialists for this particular child, neurology, pediatrics, child psychiatry, and then separately, we had consultations with rheumatology, immunology, and child psychology. We repeated some of her laboratory studies, all of which were also reassuring. And because of the severity of her symptoms, she was treated with IV immune globulins, and within about 7 days was eating normally, had a 75% reduction in her OCD, behavioral dysregulation resolved, she was sleeping. She was then treated for 12 months of monthly IVIG, was engaged in individual evidence-based psychotherapy, and as well as a very low dose of sertraline to address some of her residual symptoms of concern. So hopefully the cases gave you a little bit of a flavor of the neuroimmune psychiatric conditions that present that help us think about integrating the medical side of the work that we do in clinic and the psychiatric side. So I want to think a little bit about primary versus secondary. So I tell a lot of our families and patients that psychiatric conditions are common. They're common in children and they're common in adults. And infections are common. They're common in children and they're common in adults. And how do we understand where they overlap? This is a really important, pretty difficult question, but it's one that I think we can get at today. So anxiety disorders, for instance, are very common in children and very common in teenagers. And having an anxiety disorder is so common that it would not mean that someone does not meet the criteria for a neuroimmune psychiatric condition. I want to make sure that that's clear. You can have some mild anxiety as a child and go on to develop something that we would later call PANDAS. For adults, About 1% to 3% of adults will have something that we would call a psychotic disorder, and around 20% of adults will have a diagnosable anxiety disorder. And so when we train in psychiatry, we think about primary versus secondary. I do think, hopefully in my lifetime, that we start to talk about these criteria a little bit differently. But primary really means that a patient meets the DSM-5 criteria. The DSM is a book that describes different conditions that we can identify in psychiatry. It helps us talk shop between different people in psychiatric care and in psychiatric practice. And so things like generalized anxiety, obsessive compulsive disorder, phobias, depression. In fact, if you look at the DSM closely, primary is meant to be equivalent with idiopathic. And so idiopathic means I don't know the cause and it cannot be attributable to a medical condition. So think about that. I think when we train in psychiatry, we don't necessarily think about that or think that way. Secondary really means that the psychiatric symptoms in front of you are resulting from an underlying organic condition. Those conditions that we identify in psychiatry that are more likely to be resulting from an organic condition typically would be called OCD or psychosis, catatonia. These are conditions where it's much more likely that we're going to find an underlying medical cause. However, there are millions of people on the planet with major depressive disorder, MDD, depression, and about a third of those people are thought to have an inflammatory type of depression that responds actually to an anti-inflammatory regimen, interestingly. So when we identify someone with OCD or psychosis, some of the differential diagnosis on the medical side is listed below, and that includes things like actual antibody positive or negative autoimmune encephalitis. I'll talk briefly today about autoimmune psychosis and autoimmune OCD. PANS and PANDAS will be the focus of today. Certainly some eating disorders. Absolutely. From more exciting research from some of our colleagues at Mass General, point to very substantial evidence for many, many, many types of eating disorders being related to underlying organic conditions. And then neuropsychiatric symptoms associated with autoimmune conditions like lupus and multiple sclerosis. So when we think about primary versus secondary, why is this important? Well, it's really important because treatments targeting the underlying etiology is critical to recovery. It's very, very simple. And treatments for the secondary neuropsychiatric symptoms we see might be a little bit different. And psychiatric and psychological interventions are the same or very similar. So we're still going to need psychiatrists and we're still going to need psychologists. It just helps in this type of situation to have integrated care. And in my professional opinion, the evaluation for all of our patients should be the same. The evaluation should be there to clarify in all of our patients that it is or is not primary, that it might be a secondary neuropsychiatric condition. We can't just tell by looking. So I want to talk mostly today about PANS and PANDAS. PANDAS stands for Pediatric Acute Onset, Abrupt Onset, Autoimmune Neuropsychiatric Disorder Associated with Strep infection. These are the criteria, and this is really important, and hopefully the cases that I shared demonstrated that they did meet the criteria for these conditions. So abrupt onset, OCD and or tics, this is PANDAS triggered by strep. Prepubertal in onset, acute onset and episodic course relapsing and remitting for about 2/3 of patients, associated with neurologic abnormalities, tics, or choreiform movements. Those are abnormal movements that I can describe. And that there's a documented temporal relationship between the symptom onset or exacerbation and group A strep infection. This type of very strict criteria is very helpful when we're doing research. And I'll talk a little bit about research today. So PANS, which is a little bit broader and was described a little bit later than PANDAS by Dr. Sweeto, is pediatric acute onset neuropsychiatric syndrome. A little bit different. And most people who work and study this condition consider PANS to be the overarching umbrella, and PANS is a subset of that group. And the criteria are a little bit different: acute onset or recurrence of OCD and or eating restriction, and then additional onset acutely of these comorbid symptoms. And these are really important to understand. Anxiety, a lot of these patients have very severe separation anxiety that is not in line with their age or stage of development, or it's new. Sensory amplification, these are patients who are experiencing light, sound, and or pain amplification. Motor abnormalities, these are children who have new onset, really substantial handwriting deterioration. You might see piano fingers or other evidence of mild cuneiform movements on neurologic exam. They become very hyperactive, some of them, new onset hyperactivity, sensory seeking, and tics. Many of our patients will have behavioral regression. They'll start having baby talk, or they'll have new onset tantrums. They'll be interested in things they liked when they were younger. And deterioration in cognitive function. I have patients who will say, I can't memorize anymore. They've lost their math facts or their multiplication tables, and their drawing and their writing is just illegible. Mood disorders. These are patients who may demonstrate lability. They may act depressed. A lot of irritability and rage that looks very much out of control and very out of character. Some of our patients are very aggressive and engaging in very harmful behaviors to themselves or property or to others. And the urinary symptoms are interesting, very sensitive and specific. There's really nothing in psychiatry or neurology that has this sign. These are patients who might present initially to their pediatrician for rule out UTI or rule out diabetes because they have such severe urinary frequency and urgency, or they're wetting their pants or wetting their bed after being toilet trained for years. And these are also patients who have severe sleep disturbances. And if they have sleep studies, that this is oftentimes evidenced on their sleep study. So a brief history. I like history, and I love Sue Sweeto. She is the mother of this field and is still actively engaged in research and in providing care for these patients. And she really is just such an honor to know. She was working at the NIH, and she was trying to really characterize the psychiatric sequela and consequences of synonyms chorea. And she wasn't able to recruit enough subjects with synonyms chorea. And instead, she was able to see this new entity that she then termed PANDAS with strep, with this sudden onset of OCD and tics, lacking classic chorea, but with some choreiform movement. And diagnostic criteria were written and published in 1998. So if we look a little bit further back, when my neurology partner is giving talks with me, he does a great job describing, synonyms chorea is actually a late clinical manifestation of strep infection. It's oftentimes delayed by weeks or months after an acute strep infection. And it's still worldwide the most common form of acquired childhood chorea. Chorea means sort of abnormal movements. It is considered, and it is, an autoimmune neurologic disorder and has both neurologic and psychiatric symptoms. And so patients who have synonyms chorea have emotional lability. Most patients are irritable. They have lability to their mood, their outbursts, OCD in almost 3/4, very distractible, halting speech, poorly modulated speech. They can have physical findings, hypotonia, and these irregular choreiform movements of their face, kind of continuous restlessness. We see this a lot in my clinic. And synonyms chorea does have in lab studies antineuronal antibodies that if you take them from the serum or the CSF from patients and you bathe them on a mouse brain, the mouse brain lights up. So those antibodies are targeting neurons in the brain, very non-specifically. So when we think about synonyms chorea, we think about PANDAS. We think about synonyms chorea being an important model of central nervous system autoimmunity. This is one of the best ways that we can describe what we're seeing in PANS and PANDAS. So autoantibodies, antibodies that target neurons, develop in patients with PANDAS due to what we call molecular mimicry. That's when the body, the antibody itself, recognizes the strep protein, and there is a protein in the basal ganglia in our brains that look just like strep. And this happens more often in children who have an immune predisposition to having an autoimmune response to strep infection. So those are usually described as HLA phenotypes, and there's evidence for HLA phenotypes that are in people who are prone to developing rheumatic fever. So these end organ consequences secondary to antibody response to strep. So PANDAS was first described as the new synonyms chorea. And so very, very smart people led by Sue Sweeto, Jenny Frankovich, and a multitude of other leaders in this field got together to have a consortium, develop a consensus, to then recognize, name, and identify ways to study and treat the conditions that we now call PANS. I'm going to zoom back for a couple more minutes and talk a little bit about the research behind what we see in neuroimmune psychiatry broadly, but specifically in PANS and PANDAS. And so I've been really privileged recently to start doing some really exciting work with colleagues who do clinical epidemiologic work in Denmark. Denmark and Sweden, these are European countries that have gigantic databases that enable really robust epidemiologic studies of questions like, if you have group A strep as a child, are you more likely to develop what we would call a mental illness? And the answer is yes. And so in over 1 million children in Denmark, the outcome of interest was, if you have strep pharyngitis, are you more likely to develop a mental illness? And the answer was yes, particularly OCD and tics. You could also have non-strep pharyngitis, and you were more likely to have these outcomes as well. And then Tanya Murphy did a similar study here in the United States, and she just swabbed healthy kids, 700 of them. This is a really cool study. And if you happen to test positive for strep, you were much more likely to have tics, adventitious, maybe choreiform movements, and what we called problem behaviors. And it was much more likely if you had recurrent strep infection. So strep is a problem, right? There's more than 100 strains of strep. And some of them are very, very problematic for human health. And as we all learned during COVID, infection is associated with triggering autoimmune disease in humans, right? And so having an infection can actually trigger frank and autoantibodies that I can measure in some people. And strep is one of the biggest problems with respect to bacterial infections that can trigger frank autoimmunity. And so I want to point out on this beautiful figure that many of those post-infectious autoimmune sequelae happen to be in the brain. So that would be PANDAS. We'll talk about that today, but also Behçet's, right? So I have several patients in my clinic who are in their early 20s who have post-strep Behçet's syndrome, where they have ocular manifestations of autoimmunity, oral cavity. They have other manifestations of systemic autoinflammatory conditions and neuropsychiatric conditions. And when we think about the history of strep, you think about heart valve disease, acute rheumatic fever. We see acute post-strep reactive arthritis, Kawasaki's disease, post-strep glomerulonephritis, right? All of this points to the fact that strep can actually, in genetically vulnerable patients, and if it's a rheumatogenic, more virulent strain, can actually trigger end organ dysfunction. And I want to briefly touch on a few more basic science studies that really get at this question. This is clear mechanistic evidence for strep infection in particular, triggering the immune system, resulting in brain dysfunction. And this is Strachan Aguilar's work that was published in PNAS in 2020, a very, very reputable journal, doing a mouse model of repeat recurrent infection in the nasopharynx, which is analogous to the pharynx in people. And he was able to get at, well, why does strep cause inflammation in the brain in our patients with PANDAS? And this is why. So Th17 lymphocytes, they become upregulated after repeated recurrent strep infections. They are critical for the entry of autoantibodies into the central nervous system. That then causes activation of the immune cells, the microglia that are in the brain, and that leads to this antibody production, triggering basal ganglia inflammation, and that is what we see in PANS. And I'll talk in more detail about what that looks like. One more basic science study, Chris Pittinger's group from Yale did this very elegant study, and he's done it and done it again, both in PANDAS and in PANS, taking serum from patients with these diagnosed conditions, very classically, clearly defined in research-based clinics at Stanford and at Dartmouth. And in this study, from the Stanford samples and from Sue Sweeto's samples, showing an A, actual IgG from the serum from humans. In the second panel with those sort of red blobs, that's evidence of IgG from these patients binding to cholinergic interneurons in the striatum in the basal ganglia. So basically, it's showing that there is antineuronal antibodies in a specific area of the brain that are associated with what we see in PANS and PANDAS. The B sort of panel shows that when a patient with the red dots on the left side, which is labeled as flare, when patients are in a flare, their serum will result in a marked increase in that antineuronal antibody interneuron sort of targeted antibody production and binding. And when someone's recovered, they have a marked reduction that's measurable and statistically significant. And in the C panel, this also is seen in the patients by measuring how severe is their OCD. When their OCD is more severe, those antibodies are binding more robustly. And when they're in a recovery period and their OCD is measurably reduced, they're binding less robustly. So really getting at some of the mechanism behind what we see in clinic. Zooming a little bit back out. So as psychiatrists, we know OCD can be associated by autoimmunity and inflammation. Sometimes we treat OCD in patients with steroids and it can get better. It's pretty exciting. And so very specific autoimmune conditions that are diagnosed in rheumatology are associated with OCD. So that's lupus, multiple sclerosis, autoimmune encephalitis, and then PANDAS. And there's multiple types of mechanisms that are identified as being related to why we would assume and make this connection between OCD and inflammation, including frank autoantibodies or systemic inflammation, cytokines, other sort of spillover inflammatory models that we see in our patients, and then general immune dysregulation leading to an overactive immune response in the brain. This is a model that Dr. Frankovich from Stanford shares with us. And this is where we understand that there are many inflammatory brain conditions diagnosed by rheumatology that present with psychiatric symptoms. And sometimes they present first to psychiatry. This is really important. And so CNS vasculitis, the whole concept of basal ganglia encephalitis and vasculitis, that is back to Sydenham's chorea and PANS and PANDAS, post-mycoplasma, basal ganglia encephalitis. There are other infectious triggers that we won't have a ton of time to talk about today. Autoimmune encephalitis and cerebritis, those would include patients with lupus, Hashimoto's thyroiditis, and encephalitis, NMDA receptor antibody encephalitis, and then secondary CNS vasculitis, and that includes COVID. So there is robust evidence that PANS and PANDAS is an inflammatory disorder. And so our team, Stanford, Arizona, UCLA, there's groups all across the country. I'm working with a colleague at Stanford on a review of all the research published on this topic, and we're up to 481 papers. And so there is a lot of robust data to really identify that what we're seeing clinically in our office is related to inflammation. And so neuroimaging studies show enlargement of the basal ganglia. You can see that down on the left side of the screen. This top row of brain images, this is sort of inflammation or enlargement of the basal ganglia, and post-treatment and recovery on the bottom, the basal ganglia looks normal. Measured increased microglia activity in the basal ganglia in the setting of PANS and PANDAS. We see a lot of signs of systemic inflammation in PANS, high rates of autoantibodies, a lot of musculoskeletal conditions. We can see laboratory studies pointing to complement activation, markers of vasculitis, similar to what we see in other autoimmune conditions. There is good data to support that many patients will respond to targeting that inflammation with immune modulation, everything as simple as ibuprofen or antibiotics, which is sort of an iterative feedback loop to say, if I treated OCD with antibiotics and the OCD goes away, it's probably related to inflammation and infection. And then there's a lot of really exciting emerging basic science data, everything from the microbiome in our lab to other labs looking at really trying to find that candidate biomarker, which would make our jobs a lot easier. And I want to stop and just mention this. So I've talked a lot about autoimmune diseases and why there's overlap with PANS. Well, a lot of groups, I think, who follow these patients long term would say there are a lot of comorbid illnesses that look like and then eventually become frank autoimmune disease in many of our patients. And so many of our patients we're on the lookout for this. About 28% of patients at the Stanford team have arthritis, and about 7% will go on to develop a frank autoimmune disease. So I'm going to pause and just talk about sort of integrating all of that data to say this is a medical psychiatric group of conditions, and thinking as a holistic view can be very helpful. And so medical conditions can present first with neuropsychiatric symptoms. Strep and other infections and immune deficiencies and autoimmunity can trigger neuropsych symptoms. PANS and PANDAS is readily identified. Once you see it, it's hard to miss. And underlying immune mechanisms are very, very well defined. So I want to spend the rest of our time together talking about evaluation and treatment. If you look at the PANDAS Physician Network website, you'll find all of this. So I'm not going to go into great detail, but that consortium that came together with all of the experts in the field from all of those different specialties put together clinical guidelines for evaluation and treatment. And so the first group was really talking about psychiatric and behavioral interventions. The second, the use of immunomodulatory therapies. And the third, treatment and prevention of infections. And I would point you to the PPN website. There is excellent data on the website, as you probably know, and there are a ton of resources out there to help you think about getting started. And so if you're in a primary care setting or you're in a primary psychiatric setting or a different specialty, I think all of us want to maybe have this in mind. What's different about a typical psychiatric evaluation in my clinic or compared to what we would do if we think it might be a neuroimmune psychiatric condition? We want to really be thoughtful about family and medical history. We do a pretty classic psych exam and evaluation. We're thinking about infections, and we're looking for other symptoms or history that might point to underlying immune dysregulation. We always do a neuro exam, and then we're looking for somatic symptoms. We do oftentimes think about genetics, and I don't have a lot of time to talk about that today, but I'm happy to discuss. The history is important. And so the abrupt onset is a very critical feature, especially when we're very strict about the criteria for PANS and PANDAS in research. It's really important to know what we're looking for. And there are times when it's hard to really get at that very abrupt lightning strike onset, depending on how severe the symptoms are. For some of our patients with underlying developmental differences or autism, some of that can be difficult, and I'm happy to answer questions about that. Please remember, some of our patients who develop PANS have premorbid stuff. They have maybe some mild anxiety or school-related stuff. But this looks different, right? And the family can tell you that. Something exploded, lightning strike onset. I hear often in my clinic, this is not my child. Some of the important clinical features are the emotional lability, rage and tantrums, memory impairment. We talked before about the stuttering and baby talk and the frequent urination. Our physical exams are a lot of times focusing on any signs of systemic inflammation or infection. And so does the child have sinusitis? Are they chronically sort of inflamed or stuffy? Do they have tonsillitis, pharyngitis? Is there signs of perianal strep? Any skin rashes? Do they have evidence of, ritual hand washing or other things on their exam? The neurologic exam, it can be very focused when we're thinking about PANS, but we generally do a general neurologic exam and tics and cruciform movement. We look carefully for kind of overflow dystonia and watch carefully patients' balance and gait. I want to point out from the psychiatry lens, OCD, OCD is not always obvious to the pediatricians, to be honest with you. And so that anxious child who has new anxiety and doesn't want to go to school, really digging deep into whether or not they have obsessions or compulsions or both. Eating restriction is very common. And I do want to point out suicidal and homicidal ideation that is abrupt in onset in a child who's not yet hit puberty and does not have multiple adverse childhood exposures or events is very atypical. And it's very common for us to see in the context of PANS and PANDAS, unfortunately. This is just a kind of general list of some of the labs I might recommend if a pediatrician or another psychiatrist called to say, I think this might be PANS, what should I do? We do some general lab work, kind of a CBC and then general inflammatory evaluation. We do, if there's symptoms, look for strep with a throat culture. We sometimes will do blood work that is looking specifically for infectious triggers or underlying autoimmunity or immune deficiency. In about 10 to 20% of patients, depending on the clinic, where the differential includes other very substantial concerning things like frank autoimmune encephalitis and or seizures or an underlying neurometabolic condition. We have identified patients with MOG antibody syndrome. We've identified patients with previously undiagnosed genetic syndromes that were very helpful in sort of case conceptualization. But we do MRIs, EEGs, and LPs when indicated. And I want to point out for psychiatry here, we use validated surveys in our program repeatedly because that's very helpful, both for the initial diagnosis, but also for following as we treat. So how do we treat? I'm going to very briefly, I know you can't read this very well, but there are very, very evidence-based intervention treatment pathways for autoimmune encephalitis. And we borrow some of that in the treatment guidelines that were published for PANS and PANDAS. Similar to Sydenham's chorea, believe it or not, there's a lot of overlap there. And if you look at the top, immunomodulation, and then antibiotic prophylaxis, and then symptomatic drugs using neuroleptics and antipsychotics or psychiatric medications. And so how does that get boiled down in PANS? 3 tiers. I tell parents it's not in any necessarily better or worse. It's all important and we do all of it. We usually look for infection and then we treat it. And that can be group A strep, as I mentioned, sinusitis, otitis, skin abscesses, mycoplasma. There are a multitude of regional infections across the country and across the world that need to be evaluated and treated. And some of our patients, if they have recurrent strep, are on strep prophylaxis. Treating post-infectious inflammatory symptoms with non-steroidals, steroids, and sometimes IVIG and others. If patients then go on to develop frank autoimmunity, they're being treated by a rheumatologist with other steroid-sparing medications like methotrexate and rituximab in very severe cases, primarily using those drugs to treat the autoimmune disease. And oftentimes you'll see benefit on the neuropsych side. And then psychiatry has a really important role. CBT, ERP, parent management training, space training, you name it, we're doing it. Everything from individual therapies to intensive outpatient programs to residential treatment. We use SSRIs and second generation antipsychotics, clonidine, ADHD meds, you name it. We use it when it's needed, but we tend to use that after we've targeted these underlying etiologies because we can sometimes see side effects from the psychiatric medications that we don't see in patients who do not have PANS. 2/3 of our patients have a relapsing and remitting course. So there's some data behind using immune modulation, and just for time's sake, I'm going to be very brief. Steroids can reduce the severity and the duration of symptoms. Non-steroidals similarly can reduce the severity and duration, and IVIG has some observational studies. We just finished a sort of international randomized controlled trial of IVIG, so stay tuned. Psychiatric medications we usually bring in later, so after month 1 or 2, patients with PANS, if you start with SSRIs and SGAs or other psychiatric medications, they can have more side effects, so we tend to start with lower doses, and we tend to stay low, believe it or not. And so this is meant to represent the tip of the iceberg. On the adult side, I would say with teenagers and definitely young adults, our European colleagues are a little further ahead of us with conceptualizing and publishing guidelines around autoimmune OCD and psychosis. This looks a lot like PANS, but these are people who are a little bit older. And so they have longer stories and they've got other medical stuff. So it's a little more complicated, but acute or subacute, treatment resistant, atypical age of onset for OCD, cognitive stuff, neurologic symptoms, autonomic dysfunction. And oftentimes we'll find in these patients they had undiagnosed autoimmune disease. And similarly, autoimmune psychosis. I'm very excited about this in our teenagers and our young adults and some of our older adults in our program. There's a consensus criteria, and there's red and yellow flags and some objective findings like we see when we collaborate with our rheumatology colleagues. And so we're really excited about the idea that inflammation, both systemic and central, as well as post-infectious sequelae leading to inflammation and neuropsychiatric symptoms, are things that are starting to be talked about more in the lay press, starting to be understood more, and certainly studied more. And I'm mostly excited about it because it gives us a chance to find additional treatments that might help our patients. So take-home points. Post-infectious autoimmune or autoinflammatory neuropsychiatric conditions are likely more common than we thought. There are some red flag symptoms that you don't see in what we would call primary OCD, for instance, that can help us identify who might benefit from a more comprehensive evaluation and treatment. And we think it's possible to clarify those underlying mechanisms with ongoing research and clear evaluation pathways. And PANS in particular is pretty readily identifiable and offers opportunity for additional targeted treatments. So if you suspect it, I think that's the most important take-home message is think about it. Think about it. The physical exam and initial labs, you can do some of that in really any clinic. You can consider trying anti-inflammatories and antibiotics initially for 2 to 4 weeks. Evidence-based interventions, lower doses of our traditional medications, and you can refer to multidisciplinary clinics. And I know there's not many of us. And I hope, to be honest with you, that this is really speaks to a paradigm shift. I think it's incumbent upon psychiatry to be the last stop, to be the professionals who say, this doesn't fit. I think we need to work together to look for the underlying trigger and the underlying reason for why this patient isn't responding. That historical divide between neurology and psychiatry, I don't think there's room for that anymore. And there may be many, and there are many examples of autoimmunity impacting the brain. And neuroimmune psychiatric conditions really require a different type of treatment, and it can be life-saving treatment. I think the research, it just makes me very excited, and there's a lot happening right now in many groups across the country. And so I'll stop by really thanking a lot of the data I presented today comes from Dr. Frankovich's group and Sue Sweeto's group. We have partners across the country, including the PACE Foundation and the Manful Foundation and the NIH and many others. I'm really interested in moving the needle in this space. So I'm happy to take questions.
That was just terrific. Thank you so much. All right, we're getting lots of questions in the chat. I'm going to do my very best to cover as many of these as possible. I just want to start with a question that we've gotten quite a bit of, which is essentially if a psychiatrist suspects PANDAS or PANS, is it appropriate for them to start a medical evaluation process by swabbing for strep? And if they find strep, should they consider giving a trial of antibiotics, or are they referring to someone else?
That's a great question. I just spoke with a psychiatrist I collaborate with this week, and she said, I haven't written antibiotics in a long time. And when I talk to my residents in training here about neuroimmune psychiatry, they ask about, prescribing anti-inflammatories, NSAIDs, steroids, you name it. I do think it's appropriate for us, depending on what type of training you have. In psychiatry, certainly we do have training in medicine. It's just getting comfortable. And so, yes, you can swab for strep and you can absolutely treat. And that data is, some of the PANS specific clinics across the country will share sort of initial treatment protocols. And that's a really great place to start.
Okay, great. And then we had a question that I think is very related, which is, do you consult to other psychiatrists who are trying to figure out how to treat?
100%. Yes. 100%. One of our really important, we have three parts of the clinic. One is education, one is research, and one is patient care. And the education part is sort of across the board. We're just trying to, we would love to be partnering with other doctors across our region and the country and the world because we need more of us, right? I think we need more people who are thinking this way. And absolutely, we're happy to provide information. We're happy to provide consultation, anything we can do to help.
I saw another question just popped up about that around eating disorders. Yes, of course, it falls into the same spectrum of disorders. So thank you for asking specifically about that. We love our eating disorder clinics.
Yes. In
Do as
fact, we
much as
have some
possible.
really great partners at Mass General that have a larger program specific for eating disorders. And there's some really exciting research happening there. And so absolutely, it depends on the age of the patient and the symptom profile, but absolutely we can, if we don't know what to do, we can find our friends.
So we have a pediatric neuropsychologist who asked, I found many pediatricians do not believe in PANDAS and PANS. I have a difficult time getting them to take it seriously when I believe this could be what's going on for kids that meet all the criteria you're describing. What do you recommend I do to help these children?
That's a really, really good question. I'm not quite sure how to answer that quickly. And so what I would say, and maybe Susan, you can say this too, is to recommend say there are resources available, right? Because we're across the country today. So there are resources available, the Pandas Physician Network website, right? That is a place where you can go and you can find resources to have a consultation with a team that can provide more clarity for you. It is not uncommon for my team to evaluate and treat a child who comes from a region of the country where this isn't something that's taught or understood or treated or and then we really try hard to work with the primary care doctor or the primary psychiatrist or the neurologist who's referring to continue that care at home. I'm sure there are other resources as well. But I think that's one place I would send families.
Um, so then someone asked, what do you consider a low dose of SSRI? And do you always proceed with IVIG after a first episode if you decide to use it?
Got
Is it
it.
ongoing or is it one time?
Got it. So IVIG is reserved for patients who've tried sort of the first tier treatments, at least to start, right? So usually patients, if they are diagnosed with PANS or PANDAS, they're treated with, their infections, the low tier anti-inflammatories. And if they're very severe, where they're not eating or et cetera, IVIG can be brought in. It's not typically a one-time treatment. It's typically an ongoing treatment. And it's beyond the scope of the time we have today, but yeah,
I think
it's
it's such an
a helpful
important
endeavor.
question. Yeah, I think that's a really, really important question. I make sure you fit that one in today.
Yeah,
Um, so we were talking a little bit before this webinar about patients with Down syndrome,
yeah,
with sudden onset behavioral regression.
yeah.
And I had a question in the chat that I thought I would throw in and maybe add Down syndrome to that, which is, can autistic patients have PANDAS and PANS? And would you work this up any differently due to their restrictive repetitive behaviors?
Got it. It's a wonderful question. We actually have a clinic dedicated to the overlap between PANS and ASD at Dartmouth. And I think that's a pretty common thing for clinics that have a large volume of patients. Many of us have a large proportion of patients who have autism. I study the microbiome, and actually, I think that there is. We actually believe that patients with autism are more likely to have a post-infectious neuroinflammatory condition like PANS. So the overlap is real, whether it's on the genetics, if it's an immunologic difference, if it's related to the microbiome. We don't have total clarity, but it doesn't necessarily matter for individual patients. So is it hard to identify OCD in a patient with more severe autism? Sure. It's not hard for parents to know that there's a big change in their child, and they may respond to these types of immune targeted interventions, many of which are pretty low tier, meaning they're not difficult to implement and their side effect profile is very minimal.
I'll tag on to that by saying we had a great question I thought in the chat about why you think NSAIDs may be sometimes sufficient to treat an autoantibody mediated condition such as PANDAS and PANS when we would not typically treat seronegative autoimmune encephalitis with NSAIDs, but need a more potent and specific immunotherapy, steroids, IVIG. Why is a treatment that's not effective in autoimmune encephalitis thought to be effective in PANDAS?
That is a brilliant question. I would say there is debate about, is PANS an actual autoimmune encephalitis? Um, some people would say it's more of a post-infectious autoinflammatory condition. Um, these are somewhat splitting hairs. There are certainly times when we actually think really carefully about patients who are very severely impaired, that they need a lumbar puncture, they need a CSF workup, they need to look specifically for antibody positive or antibody negative autoimmune encephalitis. So that is a wonderful question. I would say if someone has a response to anti-inflammatories like NSAIDs and meets the criteria for PANDAS, they probably do not meet the criteria for a frank autoimmune encephalitis. That this is likely a spectrum of conditions as opposed to being completely separable. It's a great question. We stay up late at night thinking about that. Yeah.
Okay, so I have a number of questions about the microbiome. Basically asking, I would say two pieces, if you're finding anything unique in the microbiome of children with PANDAS and PANS, and if you're finding probiotics to be helpful.
It's a great question. So I study the microbiome very broadly in children in relationship to neurodevelopmental outcomes like autism and neuropsychiatric outcomes like PANS and PANDAS. And so I partner with Dr. Pavel Kiela, who is a scientist at the University of Arizona and is affiliated with their PANS clinic. And so together, so he started PANS microbiome investigations with Michael Daines and Sydney Rice. That team actually identified a clear difference in patients with PANDAS in their microbiome compared to control subjects. Now, Dr. Kiela and I and my team have been doing longitudinal microbiome investigations in PANS for about 2.5 years. And there is a pattern, right? There is a pattern, there's a difference. You can look at someone's microbiome and you can see, you can identify pretty clearly that there's a patient who has PANS and there's a patient who doesn't. And this is before you treat with anti-inflammatories or antibiotics. That's important for us to know. The downstream effect of the microbiome is the metabolomics, and that too is different between the two groups. And interestingly, the patterns you see in PANDAS look very similar to patterns in the microbiome and metabolome that you see in other autoimmune diseases like rheumatoid arthritis and lupus. So we have all of these indirect sort of markers that dysfunctional immunity is part of the reason that we see this picture in patients who we diagnose with PANS and PANDAS. Probiotics, the quick and dirty on probiotics, I counsel my families and patients that the best place to get probiotics is in our food. Food is medicine. And so we know this for patients with autism, for patients with sensitivity to gluten. I mean, you name it, we can use food as medicine. It's the most important medicine we put in our body every day. There are health promoting prebiotics and probiotics enhanced foods. Eating the rainbow feeds the health promoting microbiome, and there are foods that are enhanced with health promoting microbes, everything from kefir and yogurt to kombucha and miso and fermented foods, you name it. That's really healthy. That's actually better absorbed and works better than taking a probiotic. However, some families find probiotics to be helpful. In the autism research, including my own, it looks like instead of taking 1 or 2 probiotics, they're less helpful than taking a network of probiotics. So taking like a megaflora for kids that has multiple bugs at the same time and refrigerated tends to be more impactful. And there's really, I mean, fecal transplant has the biggest impact in most of the literature. And that's something that many of us are excited to be studying in the very near future.
I have about 30 questions myself for you, just in regards to that particular topic. So that may be an event for another day, right?
Yeah, that's pretty cool.
The last question that I have for you, there's just a lot of different related questions on this. And honestly, I'd love to invite you back to do a webinar specifically on this topic. The presentations that you showed us today, the case studies, were primarily younger children with a pretty classic onset of PANDAS and PANS.
Mhm.
I was wondering if you could comment briefly on older kids who have more complex presentations, perhaps had early onset in childhood, but now have had multiple psychiatric hospitalizations or on multiple drugs. Where do we start with those kids? And I guess, would you be willing to come on and talk about those more complex cases at a later time?
Yeah, absolutely. So I think as a pediatrician, we think about development, right? The development is the kids are on a trajectory to learning and, sort of wiring their brains. And we think now we're wiring our brains into our mid to late 20s. It's amazing. And so these types of neuroimmune, autoimmune, post-infectious, inflammatory neuropsychiatric conditions look different at different ages. And it is not uncommon in our clinic to meet a 15 or 16-year-old patient who has had multiple psychiatric hospitalizations, who, looking back, probably had a very clear picture that would meet the criteria for PANS or PANDAS, and now has what I call, not the secondary I was talking about before, but has, very classic depression because of life experiences, and has an autoimmune or autoinflammatory component to some of the other symptoms like the OCD, behavioral dysregulation, cognitive symptoms. And so that is not an uncommon presentation in our clinic. It takes more time and more testing and more thinking as a comprehensive team. And then as we move into the 20s and to the 70s and 80s, we're thinking oftentimes those are more severely ill patients from a neuropsychiatric lens, and they oftentimes have undiagnosed autoimmune disease.
Hmm. Okay, terrific. I would really love to have you back on to talk more about that. I apologize for anyone that we did not get to for questions. We will try to save those and deal with those in later webinars. And thank you all so much for being here. And especially Dr. Madan, that was an absolutely brilliant presentation, and we really appreciate your time today.
Thanks for having me.
Absolutely. Thanks, everyone. Have a great day.